Okay, what's up guys? Welcome back. So this is going to be video 2 in the GI system practice questions. We'll pick up where we left off, and we left off with toxic megacolon, so now we'll go to Ogilvie syndrome. So next question is, what is Ogilvie syndrome? What are the main causes of Ogilvie syndrome? And what is the first line treatment and then medical treatment if it's refractory to this first line treatment or if there's a perforation risk? So what are we going to do? What are we going to do first line, and then how are we going to medically treat it? So Ogilvie syndrome, that's a colonic pseudoobstruction. So this colonic pseudoobstruction is similar to an adynamic ileus, where there's not an actual physical block, but it occurs in a post-op state, secondary to meds like opioids, which slow down the GI tract, anticholinergics. So remember, acetylcholine is from the parasympathetic, which increases the muscular contraction, increases the peristalsis. So anticholinergics can cause that. Hypokalemia, hypercalcemia, so remember stones, bones, moans, and groans, abdominal groans, hypercalcemia, and hypothyroidism. Conservative treatment, first you want to do IV fluids and electrolyte correction if the colon is under 12 centimeters dilated and not severe symptoms. If it is over 12 centimeters dilated or they're unstable or there's a perforation risk, you can do neostigmine. So that's an acetylcholinesterase inhibitor. Inhibits acetylcholinesterase, which breaks down the acetylcholine in the synapse. So if we inhibit that, we're building up the choline in the synapse, and that's the opposite of these anticholinergic drugs, which are potentially one of the risk factors for this Ogilvie syndrome. So it makes sense that we give neostigmine as medical management for Ogilvie syndrome. So next we're going to go to the different forms of IBD, ulcerative colitis, and Crohn's, and then we're going to go to a few of the risk factors. So we'll do like a little bit of a matching game here. So often in a vignette, they'll give you a bunch of different aspects of the patient, and they'll expect you to know, well, is this ulcerative colitis or is this Crohn's? So we'll go through a few of those, and you'll see if you can match them up in your head as we go through them, and then we'll give the answers, obviously. So first one, which one, ulcerative colitis or Crohn's, is smoking preventative for? So smoking is actually preventative for one of those diseases. And the other one, it makes it worse. So which one for smoking? Which one is most common in the terminal ileum? Terminal ileum. Which one will lead to B12 and iron deficiency more commonly? Which one, ulcerative colitis or Crohn's, has contiguous spread proximally from the rectum? So contiguous spread proximally from the rectum, which one, ulcerative colitis or Crohn's? Which one involves the mucosa or submucosa only? Which one leads to tenesmus and urgency more commonly? Tenesmus and urgency. Which one will be more commonly having pseudopolyps? So pseudopolyps. Which one more commonly will be having skip lesions? Not contiguous, but skip lesions. Which one classically has a cobblestoning appearance, ulcerative colitis or Crohn's? Which one has classically a stovepipe sign? A stovepipe sign. Which one has a P-ANCA? Which one more commonly has a P-ANCA positivity? Which one has a string sign? Crohn's or ulcerative colitis has a string sign. Which one has ASCA antibodies? Which one has fistulas, strictures, and granulomas? So which one, ulcerative colitis, more commonly to have fistulas, strictures, and granulomas forming? Which one is more common to have perianal disease? Which one is more common to have curable? Or which one is more curable? Which one is actually curable, ulcerative colitis or Crohn's? Crypt abscesses, which one has crypt abscesses? That's a classic one. Crypt abscesses, which one? Severe bloody diarrhea, which one has severe bloody diarrhea? How about perirectal abscesses? Which one has perirectal abscesses? And lastly, on histology, creeping fat. On gross dissection, creeping fat is pathognomonic for which one? Ulcerative colitis or Crohn's? Okay, now for the answers. So smoking is preventative in ulcerative colitis, actually, and it makes it worse in Crohn's. So I guess it blunts the immune response in ulcerative colitis. Remember, it's autoimmune after all, so smoking is going to blunt the immune response. It's actually helpful for ulcerative colitis. Most common in the terminal ileum, that's going to be Crohn's. Crohn's most commonly affects the terminal ileum. And of course, if it's in the terminal ileum, B12 is going to be affected because it can't, B12 binds that intrinsic factor and gets absorbed in the terminal ileum. So we can have B12 deficiency, also iron deficiency with Crohn's, since it can be all over the GI tract. Which one has contiguous spread proximally from the rectum? That's going to be ulcerative colitis. Remember, ulcerative colitis also always spreads proximally from the rectum. Mucosa and submucosa involvement is going to be ulcerative colitis. Remember, it's more superficial as opposed to Crohn's, which is transmural, goes all the way through. Tenesmus and urgency, more common in ulcerative colitis. Pseudopolyps, that's going to be ulcerative colitis. So pseudopolyps is ulcerative colitis. Skip lesions is Crohn's. We already said contiguous spread, it was ulcerative colitis, so skip lesions has to be Crohn's. How about a cobblestone appearance? Cobblestone appearance is classic for Crohn's. A stovepipe sign. Stovepipe sign is going to be ulcerative colitis. A P-ANCA, it's important to know P-ANCA is ulcerative colitis. And what other condition associated with ulcerative colitis is also P-ANCA in the GI tract, including the biliary pathology. So that's going to be PSC, primary sclerosing cholangitis. That's also a P-ANCA positivity. So that's how you can remember both those. Ulcerative colitis and PSC are both P-ANCA positivity. String sign. String sign is in Crohn's. As the contrast moves through, you can see like more of a string. ASCA is going to be Crohn's as well. Fistulas, strictures, and granulomas, also going to be Crohn's. Fistulas, strictures, and granulomas is Crohn's. Perianal disease, that's Crohn's. Curable, ulcerative colitis. You can do a proctocolectomy, I believe. Curable, ulcerative colitis. Crypt abscesses, ulcerative colitis. Severe bloody diarrhea is ulcerative colitis. Perirectal abscesses is Crohn's. So don't get confused. There's a lot of perianal disease and perirectal abscesses in Crohn's, but perirectal abscesses are different from crypt abscesses. And if they tell you crypt abscesses, that's going to be ulcerative colitis. And lastly, creeping fat stranding is Crohn's. So creeping fat stranding is Crohn's. So next one, what ages is IBD most common in? So what ages does it typically manifest? What are the two dermatologic conditions we typically see in these conditions? So what two dermatologic conditions do we see in IBD? What is the first line steroid-sparing agent for IBD overall? Both kinds. Steroid-sparing agent for IBD overall, first line. So the most common age is going to be 15 to 35, so they're relatively young when they have this. So 15 to 35, both forms of IBD. And of course, the two dermatologic manifestations are pyoderma gangrenosum. Pyoderma gangrenosum, have to know that one. And also erythema nodosum on the shins, most typically. So erythema nodosum, most typically on the shins. Both of those are dermatologic manifestations of IBD. And we want to use mesalamine. So that's topical 5-aminosalicylic acid. So that's mesalamine, and that's your first line for this condition. Next one. A 64-year-old female complains of pain when eating, and shortly after that resolves a few hours after a meal. Pain when eating and resolves shortly after, few hours after a meal. She has a past medical history of coronary artery disease, and she's 64. She has had a 10-pound weight loss since last seeing her 6 months ago, and states because of these symptoms she often skips meals. What's her diagnosis? What's the pathophysiology of this condition as well? So this is going to be a chronic mesenteric ischemia. So a few things in the vignette gave that away. Chronic mesenteric ischemia. She's an older female. She has coronary artery disease. She's often skipping meals now because of the pain when she eats, which is a couple hours after she eats. So by the time the food gets into the gut, you need more perfusion to the gut, and the body can't supply it at that time. It's chronic. She has a history of atherosclerosis and coronary artery disease, so she probably has atherosclerosis of the mesentery as well, which is the blood flow to the gut. So that's what chronic mesenteric ischemia basically is. And again, decreased gut perfusion due to atherosclerosis, like we said, increased blood flow requirement during ingestion leads to a lack of perfusion ability and pain similar to angina. So don't miss that, chronic mesenteric ischemia. Next one, a 55-year-old male, rate controlled with diltiazem, comes to the ED complaining of acute abdominal pain that is excruciating. It is located around the umbilicus. He reports he didn't take his med the past 2 days because he didn't have a ride to the pharmacy. The physical exam is benign except for severe pain. What are you thinking of? So interesting, he was rate controlled on diazoxide, probably for AFib, comes to the ED, complaining of acute abdominal pain that is excruciating. And that's it. How do we make the diagnosis? What important finding on labs will help us determine the severity of this condition? So what do we find on labs that will help us determine the severity, and what is the treatment? So this is going to be acute mesenteric ischemia. So acute mesenteric ischemia, secondary to AFib, a clot from an AFib emboli. So an embolization to the mesentery here, acute mesenteric ischemia. How do we make this diagnosis? CT angiography, if we do have the time, we can do conventional angiography. So CT angiography, but if you do have the time, conventional angiography. However, he's in excruciating pain, this is acute, so probably CT angio. Lactate on labs, that's going to be the important finding on labs that will help us determine severity. So lactate will typically be elevated when we have death of tissue. So lactate on labs may also have leukocytosis, amylase elevation, as well as hematocrit elevation, heme positive stool as well, because remember that bowel is dying, it's been embolized and it's not getting any blood flow. And the treatment for this is revascularization. So we did the CT angio or conventional angiography. We're able to see where it is, and we can go in there and unblock that area. Next one, what does a global low flow rate make you think of? So what does a global low flow rate make you think of? Or transient colonic hypoperfusion with left lower quadrant pain and bloody diarrhea make you think of? So what is this? What are the two most common watershed, which might give it away, watershed locations for this condition to occur? What's the number one goal of treatment for this condition? So again, where are those watershed areas? What does it make you think of global low flow rate or transient colonic hypoperfusion? So what do those make you think of? So this is going to be, as you can see, ischemic colitis. So ischemic colitis, the two areas that we want to be thinking of are the splenic flexure and the rectosigmoid junction. So you can see based on the diagram right here, splenic flexure up here and rectosigmoid junction right here. And these watershed areas are where there's poor collateral blood flow between two large arterial supplies. So this is between the superior and inferior mesenteric artery and the hypogastric here and the inferior mesenteric. So these are those classic watershed areas. And you want to be thinking of when these patients get this is when there's global hypoperfusion. So kind of like a prerenal AKI where there's just not enough perfusion to the kidney. Here there's not enough perfusion to these areas, and the areas that lose their ability to get that blood first are these watershed areas again where there's that poor circulation. So those are the two areas. And of course what we need to do is restore the perfusion, increase with IV fluids and NPO. Next one, adenomatous polyps are the most common neoplastic polyps, which is the order from least to most concerning. So tubulovillous versus tubular adenoma versus villous adenoma. These are in no specific order, which is the worst and which is the best and what's in the middle. So these are adenomatous polyps. Again, tubulovillous, tubuloadenoma, and villous adenoma. Put them in order. Which form of IBD is more likely to predispose to colorectal cancer? So which form of IBD is more likely to predispose to colorectal cancer? That's one of the only ones we didn't cover up there in the IBD section. And also, what are some of the risk factors for colorectal cancer? So there's a few that we need to know. Risk factors for colorectal cancer. Okay, so it's going to be tubular adenoma, then tubular villous, and then villous adenoma. So that's relatively easy to remember. Tubular adenoma has no villous in it. This has villous, villain, you can think of bad, so these are the worst, but tubular still comes before the villous, so this is middle of the road here. And then villous adenoma, villous comes first, so these are the worst. And these are the adenomatous polyps. So tubular adenoma, tubular villous, and then villous adenoma. Ulcerative colitis is more common for colorectal cancer, so important to know, not Crohn's, but ulcerative colitis. And some of the risk factors for colorectal cancer, of course, red meat, low fiber, obesity, smoking, and processed foods. So all those are risk factors for colorectal cancer. So next, a few questions on some different types of polyps and important things we need to know. So next one is hamartomatous polyps associated with mucocutaneous hyperpigmentation is what? So mucocutaneous hyperpigmentation might be like black or blue hyperpigmentation and they're having hamartomatous polyps. What does that make you think of? Next one is, what genetic disorder of the colon is associated with a large increase in the risk of endometrial cancer or other extracolonic cancers? So what genetic disorder is this? Specifically a genetic disorder that causes the pathophysiology, that causes the increased risk of endometrial and extracolonic cancers. In what condition is a prophylactic colectomy the best chance for survival, as almost all will develop colorectal cancer by age 45, if they don't do the prophylactic colectomy? So what is this condition? Okay, so that's going to be Peutz-Jeghers. So remember, Peutz-Jeghers, if that's being said correctly, Peutz-Jeghers is the hamartomatous polyps with the mucocutaneous hyperpigmentation. The genetic disorder is going to be Lynch syndrome, hereditary non-polyposis colorectal cancer, Lynch syndrome. Lynch syndrome is the one that has endometrial cancer most commonly, and also other extracolonic cancers with it. So that's Lynch syndrome, HNPCC. And of course, the patients that will all develop colorectal cancer by 45 is going to be familial adenomatous polyposis, FAP. So they need a prophylactic colectomy for FAP. Next one, what is characteristic of right versus left-sided colorectal cancer? So what kind of things would we see on exam or in the patient with a right versus left-sided colorectal cancer? Another important one to know, what is the tumor marker for colorectal cancer? So what do we get as a tumor marker for colorectal cancer? What will we see on barium enema? What will be seen on barium enema? What bacteria is associated, interestingly, with endocarditis and colorectal cancer? So again, right versus left. What tumor marker? What are we going to see on barium enema? There's a classic sign. And what bacteria with endocarditis and colorectal cancer? Okay, so this is going to be the right, or proximal, which is more proximal, has a larger diameter, so it's associated with iron deficiency anemia and bleeding, so occult bleeding is colorectal cancer until ruled out, especially in an older adult. So right-sided is going to be more common for bleeding, whereas left-sided is more common with a bowel obstruction. So that's the most common cause of bowel obstruction in older adults. So remember, the left-sided rather, is a change in the stool diameter, so it's more narrow, so there's more pressure. So often if we have the obstruction there, it's going to take less of a tumor size to actually obstruct that area. And if you see something classic like pencil stools, that's going to be more so a left-sided bowel obstruction from colorectal cancer. The tumor marker, CEA, carcinoembryonic antigen, that's what we monitor colorectal cancer with. An apple core lesion. So don't forget, apple core lesion is on barium enema. That's significant for colorectal cancer. Apple core lesion. And don't forget also strep bovis endocarditis is associated with colorectal cancer. So strep bovis endocarditis. So next questions are going to have to do with colorectal cancer screening. So it's important to know a few things about the screening and when to do it. They might give you a patient with an age and a history, and they ask you, well, what about this patient? Based on their family member, when should we screen them? So when is the recommended screening for an average risk patient? Just a good old average risk patient, when do we screen them? How about a first degree relative that's under 60 years old? So they had a first degree relative with it and they're under 60 years old. And when do we start screening for familial adenomatous polyposis, FAP? So normally, annually at 50, you do the fecal occult blood test, and then every 10 years, if it's normal, we do a colonoscopy, or you can do a flex sig every 5. And this is all for normal patients. So normally, annually, a fecal occult blood test, and every 10 years, colonoscopy, flex sig every 5. And if you have a first degree relative under 60, then you want to do a fecal occult annually, and then at 40, you want to do a colonoscopy, and you want to do that every 5 years. And it's important to know, let's say they were 55, then you want to start that earlier, 10 years before the relative had cancer. What if they had colorectal cancer at 43? Then you want to start at 33, for instance. And when do we start for familial adenomatous polyposis? We want to start at 10 to 12 years old with a yearly flex sig. So 10 to 12 years old with a yearly flex sig. And we already said that by 45 years old, they're going to definitely have colorectal cancer, so they need to do a prophylactic colectomy, often when the patient has of age to consent to this surgery. Okay, next one. A 21-year-old female comes in complaining of abdominal pain. She states this has been on and off and experiences diarrhea, but sometimes constipation. She states that it's better upon defecation, but never fully cured. What are you thinking of? So again, 21 years old, abdominal pain, on and off, diarrhea, sometimes constipation, better upon defecation, but never fully cured. What are you thinking? Important to know, what are the 3 proposed pathophysiologic mechanisms of this disorder? What are the medical treatments after the first line attempts at relieving constipation have been attempted, such as polyethylene glycol, fiber, and psyllium? So after you've done these, what then can you use for the constipation? And how about if diarrheal symptoms predominate? What are you going to use in that case? So this is going to be IBS, irritable bowel syndrome. So IBS, it's going to be the 3 pathophysiologic mechanisms that are proposed are an abnormal motility of the gut overall. So abnormal motility could be visceral hypersensitivity, so mismatch in pain signals, so they experience pain a little bit differently from the GI tract. So visceral hypersensitivity, and also psychosocial interactions. So something potentially psychosocial going on. So psychosocial, visceral hypersensitivity, and abnormal motility. What can we use for the constipation after we already tried a few things like polyethylene glycol, fiber, and psyllium, which are our first lines? We can do some classic treatments for this called lubiprostone and linaclotide. So lubiprostone and linaclotide, and I've had actually questions about these, so they definitely do ask it. Lubiprostone and linaclotide for constipation. And what if they're refractory to conservative management for the diarrhea? Then what are we going to do? Then we can do loperamide, works on opioid receptors, loperamide. We can do dicyclamine or hyoscyamine also, and these are antispasmodics. So again, for this diarrhea, loperamide, dicyclamine, and hyoscyamine, and for the constipation, lubiprostone and linaclotide. And also important to know, I just put it in here, the Rome 4 criteria is how you diagnose it. You need to have a change in the frequency of the stool, the form of the stool, and it also needs to be related to the defecation itself. So like we saw in this patient, it got better after defecation. And you need 2 or 3 of these, and it has to be happening for over 1 week for at least 3 months. Okay, next one. A 55-year-old male with HIV comes in complaining of difficulty swallowing. What condition is at the top of your differential with this limited info? So all you know is that 55 years old, he has HIV, and now he's having difficulty swallowing. What is this? What does the endoscopy find? So you do an endoscope, you look in the throat, and what does it find? And here's a couple other ones. If you see linear yellow-white plaques on the endoscopy, what is that? If you see large, superficial, shallow ulcers, what would you think that is? If you see small, deep ulcers, what will you think that is? So again, HIV, difficulty swallowing. What do you see on endoscopy? How about linear yellow-white plaques? How about large, superficial, shallow ulcers? How about deep, small ulcers? So this is going to be esophageal candidiasis. So you always want to be thinking if they're immunocompromised and they're having dysphagia, you want to think candidal esophagitis is the most common cause. In the first one, yellow, linear, white plaques, that's going to be candidal esophagitis, a description of what you'd see on this endoscopy. And you want to do fluconazole for that, orally, of course, so it actually hits the fungus that's in there. CMV, large, superficial, shallow ulcers, that's going to be CMV, cytomegalovirus, and the treatment is ganciclovir. So how I always remember this is it's large, superficial, shallow ulcers, so cytomegalovirus, mega equals large, so large ulcers, cytomegalovirus, and ganciclovir is the treatment for that. HSV, small, deep ulcers. So small, deep ulcers, you're going to treat with acyclovir for HSV esophagitis. Next one, a 12-year-old male with a past medical history of atopic dermatitis. So 12-year-old, atopic dermatitis, now he has dysphagia. Endoscopy gives it away by saying he has multiple corrugated rings. What is the diagnosis? So multiple corrugated rings, history of atopic dermatitis, and now dysphagia. What is this? And what is the treatment for this condition? So this is going to be eosinophilic esophagitis. So eosinophilic esophagitis. So remember the classic atopic triad. One of those things is atopic dermatitis, also allergic rhinitis and asthma. So they can have any of those, and they can also have dysphagia, which would clue you into the eosinophilic esophagitis. And typically in kids this occurs. And classically, like we said, the multiple corrugated rings for eosinophilic esophagitis. And the treatment is the use of inhaled corticosteroids without a spacer, however. So without a spacer is going to help it get into that throat, get into that esophagus more specifically. Whereas if you did use a spacer, that's going to help more the lungs and the respiratory tract there. So without a spacer is the treatment for eosinophilic esophagitis, because it is eosinophils after all. So we want to use an anti-inflammatory like corticosteroid. Name the most common pills that induce pill esophagitis. So there's a few that we definitely need to know. Name the most common pills that induce pill esophagitis. And sometimes they even give you some of the most obscure ones too in the vignette. So this is going to be NSAIDs, of course, can cause it. Bisphosphonates is the most important one to know. So bisphosphonates, most common to cause pill esophagitis, importantly. And don't forget the black box warning, osteonecrosis of the jaw for bisphosphonates. It can also be potassium chloride, beta blockers, calcium channel blockers, iron pills, and vitamin C. So these can all cause pill esophagitis, but most commonly NSAIDs, bisphosphonates, and I got a question before, and the answer was potassium chloride causing pill esophagitis. Okay, next one. On radiograph, you incidentally find that the gastroesophageal junction of a patient is moved superiorly into the mediastinum. The patient admits to some recent reflux. What is this a description of? So you found that the GE junction of the patient moves superiorly into the mediastinum. What is this? What if the fundus of the stomach protrudes into the diaphragm with the GE junction actually in place still? So what if it kind of flips and the fundus is now in the stomach and the GE junction is not prolapsed superiorly? So this is going to be hiatal hernia, type 1 sliding. So sliding is just when the GE junction kind of slides up through the hiatus rather, and then paraesophageal is the second one where we have the stomach protrude through into the diaphragm and the GE junction remains in place. Next one, a newborn presents immediately after birth with excessive oral secretions. Immediately after birth. There's also choking, inability to feed, and distress. You note that an NG tube cannot be passed into the stomach. What is the likely diagnosis? So what gives it away is an NG tube cannot be passed into the stomach. What is this in a newborn? What might this infant have? Why might this infant have respiratory distress? So why might this infant have respiratory distress? Important thing to know. And lastly, what is this condition associated with? So what is this condition associated with? That's going to be esophageal atresia, so lack of formation of the esophagus fully. There's a high risk of aspiration pneumonia, so that's what we want to be concerned for. And why is there a high risk of aspiration pneumonia? Of course, because nothing's going through and they're just coughing it back up, and that can go, of course, into the respiratory tract. But also, it's most commonly associated with a tracheoesophageal fistula. So connection between the trachea and the esophagus. So obviously if you're just putting stuff into that baby's throat, it could be going right into their lungs if they have a fistula, which this is highly associated with. So again, esophageal atresia, high risk for aspiration pneumonia, and most commonly associated with a tracheoesophageal fistula. So next one, patient comes in with complaints of heartburn. He says it's worse at night when he lies down, as well as after spicy meals and alcohol. He smokes, and he notes it seems worse after the nicotine as well. Sometimes he admits to a cough and a sour taste in his mouth in the morning. He also admits to some weight loss, some dysphagia, and occasional bleeding. What is the first test you want to do? So taking all that in the vignette, some typical things, some atypical things, what is the first test you want to do? What is the gold standard for the diagnosis of typical symptoms? What cellular changes do you see with Barrett's esophagus? It's important to know. What cellular changes do you see with Barrett's esophagus? And also importantly to know what type of cancer can result from Barrett's esophagus. So this patient, it's important to know, they always give you questions on this. You want to do an EGD in this patient. So why do we want to do an EGD as opposed to other tests? because there's the presence of alarm symptoms. And in this patient, it was weight loss, dysphagia, and also bleeding. So if you find alarm symptoms, you want to go in and do the EGD right away. These are concerning for malignancy or something more complex than simple GERD. And to explain that further, typical symptoms, the gold standard is a 24-hour pH monitor. So gold standard for typical symptoms, no alarm symptoms, is a gold standard 24-hour pH monitor. And we're explaining Barrett's esophagus cellular changes. It's important to know that the squamous epithelium, the typical lining of the esophagus, changes to a precancerous metaplastic columnar from the cardia of the stomach. So basically the body, how I think of it as the body tries, the esophageal tissue is not used to all that acid refluxing, so the body's going to try to reinforce it and put some heavier duty cells there, which are the columnar cells as opposed to the squamous epithelium. And this is from the cardia of the stomach, so that most top portion of the stomach right before it enters the esophagus, that's some pretty hefty cells there. So your body's basically trying to put some of those cells there, and this is going to be precancerous metaplastic columnar, however, as it tries to reinforce that area to withstand the attacks of acid over time. And what type of cancer can result from Barrett's esophagus? That's going to be adenocarcinoma. So it's important to know in that distal esophageal portion is adenocarcinoma. Next one, what is the surgical procedure called in medication refractory GERD patients? So what do we do for surgery in medication refractory GERD patients? What is the most common type of esophageal cancer in the U.S.? What is the most common type of esophageal cancer in the U.S., however? How about worldwide? So what's more common worldwide? What's more common in the U.S.? If you find cancer in the upper 1/3 of the esophagus in an African American, what type would you think it is? So upper 1/3, African American, what type would you think it is? So of course, the surgical procedure in medication refractory GERD is going to be the Nissen fundoplication. And that's when they basically take part of the stomach and kind of fold it over the gastroesophageal junction and suture it up or tie it up, and so that it withstands and reinforces that area to give it a little bit more solidity there. So that's a Nissen fundoplication. Adenocarcinoma is the most common type in the U.S. Adenocarcinoma, which remember we said it was from Barrett's, and more common in the distal part, which we said, and also in Caucasians. So Caucasians, most common for adenocarcinoma. And squamous is the most common worldwide, and that's more common in African Americans and also the upper 1/3 proximal esophagus. So again, squamous cell, African Americans, upper 1/3. Adenocarcinoma distal, you can remember that because we talked about that with Barrett's, and Barrett's is having to do with the changes in the GE junction. Next one, alcohol is not a risk factor for what type of esophageal cancer? So a few esophageal cancer questions here important to know. Alcohol is not a risk factor for which type? What are the two biggest marker symptoms for esophageal cancer? So what would really clue us off in the vignette if they mention these two symptoms? How do we diagnose this cancer as well? So alcohol is not a risk factor for adenocarcinoma. So think about adenocarcinoma as a risk factor. Think about squamous cell having alcohol as a risk factor because all that alcohol, like when you're drinking it, it like burns the upper 1/3 of the esophagus as it goes down. So that's how I think about that as a risk factor for the squamous cell carcinoma, and that's in that upper 1/3 of the esophagus, proximal. So again, alcohol not a risk factor for adenocarcinoma in the distal portion. Progressive dysphagia as the tumor grows in size. So they're having classically progressive dysphagia. So they might say, and of course weight loss. Weight loss is classic for cancer. You always want to be thinking of cancer with an unintended weight loss. But also solids and then liquids. So they were eating solids fine, and they were eating liquids fine, and now it's progressed from solids just having a trouble getting it down to now liquids, where the cancer could be plugging up the whole diameter, the whole lumen of the esophagus. So progression from a solid to then not being able to have any liquids go through there at all. So that's when the tumor grows in size, and those are your classic those are classic symptoms rather of esophageal cancer. And of course, you want to do upper endoscopy with biopsy. Go in there with an EGD and take a sample of that tissue. So next one, a patient is 35 years old and he complains of difficulty swallowing both solids and liquids at the same time, however. at the same time, with occasional regurg of undigested food. On manometry, the most accurate test in this condition, you see an increased lower esophageal sphincter pressure and a lack of peristalsis. What is this? So very interesting. Lack of peristalsis. You did manometry, the most accurate test, which clues you in. You see an increased LES pressure, and he's having occasional regurg of undigested food, so it's not getting into the stomach. And it's difficulty swallowing solids and liquids at the same time. Okay. What do you classically see on X-ray? What is the pathophysiology of this condition? So what do you classically see on X-ray? What's the pathophys? What are some treatment options? And what should you do for procedure or imaging prior to treatment to rule out other causes? So important one. What are you going to do prior? What are you going to do for a procedure or imaging prior to treatment to rule out other causes? So this is going to be achalasia. So achalasia, it's important to know, classically on X-ray, that's the bird beak appearance. The pathophys is a failure of relaxation of the lower esophageal sphincter due to degeneration of the Auerbach's plexus of nerves that controls this area. So it's not going to be able to relax. So you're basically having like a one-time super strong peristalsis of that lower esophageal sphincter area that's not relaxing, not letting food go down there. So that's why you get that bird beak appearance and gathering of barium. Again, this leads to inability to relax the LES. What are some of the treatment options? You can do calcium channel blockers as well as nitrates to try to relax the opening. But you can also do Botox if it's refractory to that. Pneumatic dilation, where you actually open it up with an air pump, kind of. But the most effective is a Heller myotomy, which is an esophagomyomectomy, basically, where you just cut open parts of that from the outside to allow food to basically go down there. So that's achalasia. And don't forget those classic things for achalasia. Manometry, the most accurate test. You're just going to test the pressure there. Occasional regurgitation of both liquids and solids at the same time. So if that LES is squeezed tight, nothing's going to go through there. So that's when you know it's both solids and liquids. You might think solids and liquids esophageal cancer, but it's a 35-year-old, and this is at the same time. So that means not all the time this is happening. Okay, next one. Oh, and of course, the last question, what do we want to do first? We want to do an EGD first to rule out cancer, since achalasia is actually a risk factor for esophageal cancer anyways. So again, EGD to rule out cancer first, since achalasia is a risk factor for esophageal cancer, and we'll see that again later. So a 73-year-old male complains of recurrent bad breath that his wife is upset about. 73 years old. He reports an occasional lump in his neck and regurgitation of undigested food. So lump in his neck, undigested food, what is this? What's the pathophysiology of this condition? How does it arise? And how do we diagnose it? So you should be thinking of Zenker diverticulum. Zenker diverticulum. So it typically happens in patients over 70, he's 73, and halitosis is the hallmark because basically it's an outpouching of the pharyngoesophageal pouch that is a false diverticulum since it only involves the mucosa and submucosa, and it's due to weakness of the junction at the Killian's triangle between the cricopharyngeal muscle and the inferior muscle below that. So you're having this weakness, this outpouching, and when you do a barium esophagram, the collection of dye is going to be in there. So if you think about it, if they're eating and drinking food, food's just going to collect in that outpouching posteriorly, and it's going to get kind of, time's going to go by, and that's going to get kind of gross. So you're going to have a halitosis from that for sure. And then you're going to have some regurgitation at times, and of course it's going to be undigested. So you want to be thinking of the older guy with this. And again, that's Killian's triangle, the junction of Killian's triangle. Next one. This is an important one to know. What is the difference between a distal diffuse esophageal spasm and a hypercontractile jackhammer or nutcracker esophagus? So what's the difference between these two? Which one has a corkscrew pattern on esophagram? And what is the first-line treatment for both of these conditions? So again, what's the difference between a distal diffuse esophageal spasm and a hypercontractile jackhammer nutcracker esophagus? Which one has corkscrew and what's the first-line treatment? So the difference is the pattern seen on manometry. If it's the diffuse one, distal diffuse esophageal spasm, it's going to have increased simultaneous and premature contraction without coordinated peristalsis. So you can think spasm is, of course, just a spasm. It's not going to be a simultaneous peristalsis that actually pushes the food down. Jackhammer or nutcracker esophagus is going to be hypercontractile, and it's basically just a super strong peristaltic function. It's basically your same esophageal function, except it's super strong. It's a super strong peristaltic movement that pushes everything down. So this is just, it retains its peristaltic function. It still pushes the food down, and you're going to have that increased pressure during peristalsis. So one, distal diffuse esophageal spasm is, again, uncoordinated peristalsis all over the place, just spasming, whereas the other one is just hypercontractile and it pushes it down. So corkscrew, of course, therefore would be random, so it would be the diffuse distal esophageal spasm. So in that corkscrew pattern, just all over the place. And you want to do calcium channel blocker for both. And again, so you need the manometry to really see this. So patients can tell you about the symptoms, but manometry is where you actually see physically the difference between these two. And you can see one being peristaltic and one just being a random spasm, supercontractile spasm there, a corkscrew pattern. So next one, a patient comes in with retrosternal chest pain that is worse with deep breathing and swallowing. They state a binge of drinking occurred last night with subsequent vomiting harshly. You feel a cracking and popping feeling when palpating the chest, as well as auscultating the heart in the left lateral decubitus position. What is this? So important things: binge of drinking, subsequent vomiting harshly. It's worse when they deep breathe. And also when you're palpating their chest, you have this sensation of crackling and popping, and you also hear that when you're auscultating in the left lateral decubitus position. What is this? So what are these classic signs called? Where does this occur anatomically? So what's the anatomical information based on this condition? And what will we see on chest x-ray in this condition? And what is the diagnostic test of choice specifically? So what are the classic signs in this condition? Where does this occur anatomically? So where actually is this going on? What are we going to see on chest x-ray? And what do we want to do for a diagnostic test for this? Interesting. Okay, so this is going to be Boerhaave syndrome. The mortality is very high. It's 40%. So that crackling and popping, that was Hammond's sign, an important one to know. So Hammond's sign with Boerhaave syndrome. And it's also crepitus on chest auscultation. The anatomical area, the left posterior lateral wall of the lower esophagus is most common. So lower esophagus is the most common for this. The chest x-ray will see pneumomediastinum, so air around the mediastinum. And you'll basically see radiolucent lines around the mediastinum on the x-ray. Contrast esophagram with gastrographin should be done. So this is important to know what the diagnostic test is. So we need to see what's going on with the esophagus. We want to do esophagram, but we don't want to use barium because barium is caustic. If it leaks into the lungs, it can really damage the lungs pretty severely. So we want to do the gastrographin. So gastrographin is not as toxic if it does extravasate from the esophagus. And of course, this is an esophageal rupture, so that's Boerhaave syndrome. And we should also know how to tell this different from Mallory-Weiss tear as well. And important to know again, Hammond sign. Okay. How do we differentiate this from Mallory-Weiss tear? So that is the next question. So how is this different from Mallory-Weiss tear? So Mallory-Weiss tear, this is going to be a superficial and longitudinal laceration, basically, in the area just proximal to the lower esophageal sphincter, and it does not perforate through the mucosa. So the important difference is that Boerhaave's is a complete perforation through, and Mallory-Weiss tear is not. It's just a longitudinal laceration down there. It's also most commonly from retching and vomiting in young people after alcohol binge. So it's both of the similar causes, and this is also a commoner cause of upper GI bleed, but way lower mortality and is treated conservatively. And you just want to basically let it heal by decreasing the stomach acid, refluxing up against it, and that's done with a PPI. So again, Mallory-Weiss tear, a longitudinal laceration that does not perforate through, superficial mucosa. Okay, next one. What is Plummer-Vinson syndrome? So Plummer-Vinson syndrome, that's a triad of a few different things. Kind of important to know, Plummer-Vinson syndrome. What is the esophageal web most common? So where is the esophageal web most common? Where is an esophageal web most common as compared to a Schatzki ring? So where is a Schatzki ring more common? So it's important to know, is it distal or proximal esophageal web or Schatzki ring? What is the biggest risk factor associated with the Schatzki ring? So biggest risk factor associated with the Schatzki ring. And what is the best test for both of these conditions? So again, Plummer-Vinson syndrome, what is that? It's a triad. Where is the esophageal web? Where is the Schatzki ring? What's the biggest risk factor with the Schatzki ring? One that we should know. And what is the test for both? So Plummer-Vinson syndrome is an upper esophageal web, which gives it away. So upper esophageal web, iron deficiency anemia that can manifest as atrophic glossitis, koilonychia in the nails, and other findings of iron deficiency anemia that could be chronic. And also dysphagia. So dysphagia, iron deficiency anemia, and upper esophageal webs, that's Plummer-Vinson syndrome. And a web is more common in the cervical area, so proximal, and that's the upper esophageal region. So a Schatzki ring, that's going to be more inferior then. So Schatzki ring is more common lower in distal, and the risk factor is a hiatal hernia. So how I remember this, a hiatal hernia, remember a type 1 anyways, is the GE junction sliding up through the hiatus, and that leads to regurgitation. So you can think of this as the body's mechanism to create a ring to kind of stop some of that reflux from damaging and getting further proximal up the esophagus. So you have that ring just above the lower esophageal sphincter that I guess you can think of as your body's mechanism to stop, prevent some of that acid from leaking up. So that's how I remember that hiatal hernia, which is associated with some reflux, is a big risk factor for a Schatzki ring. And again, web is in the cervical region, and that's Plummer-Vinson syndrome associated. And again, barium esophagram is good for both of them. So they're really going to show a nice outline when you put the barium down the esophagus, and then you take the image. It's going to show a nice line of both of them. So next one, a patient with a history of cirrhosis comes in with an acute upper GI bleed. What is it? So we should know this one. Cirrhosis, acute upper GI bleed, what is it? What will you find in the stool of an upper GI bleed? So there's a specific descriptive term that you should know for an upper GI bleed, and what do you find in the stool, or what is it called anyways? What is the next step that is diagnostic and therapeutic in this case? Diagnostic and therapeutic. And what is your acute management? So there's a few things we do as an acute management. So there's a few very important steps that we need to take for a bleeding something here. So again, history of cirrhosis, upper GI bleed, what is it? What is it called in the stool? What is diagnostic and therapeutic? And what's our acute management? Three main things that we need to know. Okay, so that's going to be esophageal varices, of course. Portal hypertension backs up into the esophageal veins around the lower esophageal sphincter, as well as the left gastric vein on top of the stomach. Melena is what we'll find in upper GI bleed. The blood hemolyzes and oxidizes as it goes through, gets digested, and then by the time you poop it out, it's melena. So it's a real dark black color, and that's typically due to an upper GI bleed. Endoscopy is diagnostic and therapeutic because we need to do a ligation through that endoscopy, and we need to diagnose it by actually looking at it. So endoscopy is diagnostic and therapeutic. And how I remember the acute management of a bleeding varices is LOL. So LOL, that's easy to remember. LOL, liquids, octreotide, and ligation. So LOL, liquids, octreotide, and ligation. So you shouldn't be laughing in this condition, but liquids, octreotide, and ligation. And of course, for liquids, IV fluids, 2 large bore needles, 2 large bore catheters may be needed, and also fresh flows in plasma potentially, because this is due to liver failure after all. So we're going to have a decrease in those synthetic functions, like we said before, and we're going to have a decrease in those clotting factors. So we may need FFP in this case too, as part of our liquids. For octreotide, LO, that's going to be a somatostatin analog. It vasoconstricts the portal venous circulation specifically. So it's a more specific vasoconstrictor that we can give. So that's octreotide. And then ligation. So we want to do ligation, which is better than balloon or sclerotherapy. So ligation itself is better than balloon and sclerotherapy here in this case. So LOL. Okay, next one. What procedure can be done if refractory to all of the above? So what procedure can be done if you're refractory to all of the above? What meds can help us prevent the rebleed in this case? And what do we give antibiotics for? Or rather, why do we give antibiotics? So again, We already did LOL, but what procedure do we need to do if it's refractory to all that? And this is a very procedure thing. What meds can help us prevent the rebleed, and why do we give antibiotics? Okay, so we do the TIPS procedure, the transjugular intrahepatic portosystemic shunt. So basically putting in a stent that bypasses the liver, so the blood stops going to the esophageal varices, basically, and it shunts it past the liver. But once we go to the hepatic vein, from the hepatic portal vein, that's kind of bad because we're just shunting everything the liver was supposed to be doing, like detoxing all that stuff, and that's getting shunted right to the brain. So we can have a risk of encephalopathy with this. But if we don't do this sometimes after we do the LOL, then they could die. So basically save their life, but send toxins to their brain and risk encephalopathy. We want to do, to help them prevent this, non-selective beta blockers like propranolol. So important to know that propranolol and non-selective beta blockers are given after the varices. And we want to give ceftriaxone for spontaneous bacterial peritonitis. So spontaneous bacterial peritonitis is why we give antibiotics in this condition. So one more here. What is autoimmune-mediated inflammation of the small bowel due to a reaction with alpha-gliadin called? So an autoimmune-mediated inflammation of the small bowel due to a reaction with alpha-gliadin called? What dermatologic condition is associated with this? And also, what are some of the symptoms of malabsorption? So what do we see, some of the symptoms of malabsorption? So as I go through the questions, you can kind of get a sense of what this is if you don't know. What would a biopsy as the definitive test of the small bowel show? And also, how do we screen for this? So again, the questions are autoimmune-mediated inflammation of the small bowel due to reaction with alpha-gliadin. It has one important dermatologic condition associated with it. What are going to be the symptoms of malabsorption that are important to know? What would a biopsy show? And how do we screen for it? So this is going to be celiac disease. So celiac disease, it's associated with dermatitis herpetiformis, which is the dermatologic condition. Some of the symptoms of malabsorption, that's going to be steatorrhea, lack of fat absorption, floating stools, oily stools, steatorrhea, diarrhea, growth delay in kids, we're not absorbing enough nutrients, bloating, and abdominal pain, of course. A biopsy would show atrophy of the villi, which would normally absorb these nutrients. So the villi, those tiny projections that increase the surface area of especially the small intestine, if we're having atrophy of those and flattening of those, we're going to have impaired nutrition, impaired nutrient absorption, and that's going to be a problem. How do we screen for this? There's a few different screening things that we can do, and they all have A in them. So that's how I remember them, A. So alpha-gliadin, IgA, tissue transglutaminase, and endomysial IgA antibodies. So remember, IgA coats the mucosa and the gastrointestinal tract as well. So again, how do we screen? IgA, tissue transglutaminase, I believe that's the best one, endomysial antibodies, and alpha-gliadin is the reaction against it. Okay, before we go to the next one, we'll stop there and we'll pick up where we left off in episode 3 of GI questions. Don't forget to subscribe if you do like these videos and want to see more, and go ahead and like it if you do indeed like it.